All right, so this is live on Facebook. So good morning, good afternoon, good evening. I'd like to take this opportunity to welcome everyone. We'll go ahead and we'll get started. I will take this moment to share the screen and we can go over the housekeeping rules. I would like to welcome our speakers today. So our moderator is Hannah Simba. She's a PhD candidate at Stellenbosch University in South Africa. Our guest speakers are Dr. Catherine K. Mwaba, who's a clinical and radiation oncologist in Zambia at the Cancer Disease Hospital. And our other guest speaker is Dr. Miriam Mutebi, who's a breast surgical oncologist in Kenya. I will hand this over to our moderator, Hannah. Good morning, good afternoon, good evening to everyone. We have this streaming live on Facebook. We do have this as a webinar, so those who are in the webinar, you can type your questions in the chat box in the Q&A. Hannah will review all the housekeeping rules. I will sign off and hand it over to you, Hannah.
Thank you, Dr. Asenbang. Hello, everyone. My name is Hannah, and like Dr. Asenbang said, I will be moderating this session. So before we start, I'm just going to go through some housekeeping rules and information. First of all, this webinar will be recorded. So before we start, I'm just going to go through some housekeeping rules and information. First of all, this webinar will be recorded, and the recording will be available at our Facebook page and at the PERHA website. Participants will only be in the listen-only mode, but however, if you have any comments or questions, you're welcome to post this on our Q&A platform, on our chat platform, and if you're joining us from the Facebook Live, you can send us a comment or a message there. We don't have any scheduled breaks, so if you need a break, please feel free to excuse yourself. And we hope that you enjoy this forum, and thank you to the panelists for taking the time and for our attendees for participating. So I will now introduce our panelists, and I'll start with Dr. Miriam Mutebi, who is a breast surgical oncologist from Kenya, an assistant professor in the Department of Surgery at Aga Khan University Hospital in Nairobi. She's also the Vice President of East Africa and the African Organization for Research and Training in Cancer, IOTIC, the Treasurer for the Kenya Society of Hematology and Oncology, and on the Board of Directors for the Union for International Cancer Control, UICC. She's also the co-founder of the Pan-African Women's Association of Surgeons and part of the Kenya Association of Women Surgeons. She did her general surgery residency at AKU, and she subsequently did a 2-year fellowship in breast surgical oncology, which included a year in plastics and reconstruction at the University of Cape Town in South Africa. She then worked for 2 years as a surgical oncology research fellow at the Memorial Sloan Kettering Cancer Center in New York, and also completed a master's degree in clinical epidemiology and health systems research at Weill Cornell University, New York, with a focus towards understanding the barriers to the diagnosis and treatment for women with cancers in Africa. Thus designing interventions to mitigate these barriers. She's an avid supporter for the education and support of women, especially in surgery, and she aims to provide mentorship for women in surgery and to improve women's health and surgical care on the continent. In her paper, Africa Rising, Gender Journeys of Women, Patients and Providers, which was published in the Lancet Journal in 2019, she expressed hurdles that both patients and physicians have to overcome, and highlighted how in sub-Saharan Africa, women are frequently not the main determinants of their own health-seeking behavior. Treatment is often decided by the broader community, resulting in many women losing their voices. Experiences like this drive her to continue to inspire women and to pursue fields where their impact is much needed. She's currently pursuing a pilot's license in order to extend breast cancer services to marginalized areas. Welcome, Dr. Mutebi, and we are very honored to have you with us.
Thank you, Hannah. Thank you so much for the Thank you so much for the very kind introduction. Looking forward to an excellent discussion.
Looking forward to it too. I'll then introduce Dr. Catherine Mabwa, who is the head of clinical and radiation oncology in Zambia. She's one of the first 4 Zambian radiation oncologists to have pioneered oncology in Zambia. She graduated from the St. Petersburg Pediatric State Medical Academy in Russia and later specialized in radiation oncology at the University of Witwatersrand. She has worked at the Cancer Disease Hospital since 2007 and in her capacity as project counterpart of the IAEA supported national projects, was involved in developing the first local training program of radiation therapy technologists. She has served as project coordinator on several national projects since 2007 and was nominated to serve on the African Regional Cooperative Agreement for Research, Training, Development related to Nuclear Science and Technology Management Committee in 2018, where she chairs the Partnership and Resource Mobilization Committee. She served as a consultant on the ABCDO study for the Zambia site and has co-authored research manuscripts that have been published in peer-reviewed journals. She's co-PI on a research project focusing on establishing a database on breast cancer and cervical cancer to help answer research questions. She has the breast cancer unit and is a hands-on clinician and currently serves as co-chair of the breast cancer subcommittee of the National Cancer Control Technical Working Group. She's a recipient of the International Development Education Award and has served on the ASCO Multidisciplinary Cancer Management and the International Development Education Award committees on a voluntary basis. For her contribution to cancer control, she was awarded for Outstanding Clinical Oncology Practice Service on the 14th of August 2020 and at the Second Cancer and Palliative Care Cancer Conference. Thank you so much for joining us, Dr. Catherine. We are very honored. Dr. Mabwa, we're very honored to have you with us.
Thank you so much, Hannah. I think we'll get rid of the doctor. Just Kathy will do, or Catherine,
Oh, awesome.
to make it more, not too scientific, and maybe people will feel more comfortable. So feel free to call me Catherine.
Okay.
Looking forward to the discussions.
Thank you. So I think we'll get right into it, and I'll start with you, Catherine. If you can give us a brief introduction of what breast cancer is. And I know this sounds like a very small question, but I'm sure it's pretty loaded. So we can start with the basic introduction of what is breast cancer.
Thank you. So breast cancer is cancer of the breast. I'm always accused of using very big technical terms. So what the breast is composed of cells like different tissues, and of those cells, if they become abnormal, they begin to form a growth, and basically that is what breast cancer is. So I hope that is adequate. So a malignant growth or an abnormal growth in the breast that arises mainly from the cells that form the tissue in the breast.
Okay. And what are some of the breast cancer trends in Africa? And I would direct that to you, Dr. Mutebi. If you can elaborate more on what the breast cancer trends are in Africa and how they compare to other breast cancer trends around the world, and if there's disparities, why those are there.
Thanks, Hannah, and please call me Miriam as well if I'm trying to look around for Dr. Mutebi. Sounds super formal. This is chilled, Sunday afternoon discussion, and sort of looking at, I would say, international trends. We do know that breast cancer is the most common cancer, globally, and 1 in 6 women is at risk of developing breast cancer in their lifetime. Now, while what has happened is that traditionally we've seen the highest incidences of breast cancer sort of occurring in developed countries, what's happened is that we are seeing a shift where we are seeing more and more more and more new cancer cases and more patients getting diagnosed with cancers. And if we look at sort of the global projections from the World Health Organization, they're saying that we're looking at least 20 million new patients by the time we're getting to about 2030. And what we're seeing is that at least 3/4 of these patients are going to be coming from developing countries, of which the most of sub-Saharan Africa forms quite a number of these countries. And I think what's even more concerning is, even despite the incidence, what we see is that more than 70% of cancer deaths occur in developing countries. And these are, again, involve most of the countries in sub-Saharan Africa. So what happens is, despite having a lower incidence of breast cancer in most African countries, and this can range anywhere from, say, 27 per 100,000 in Southern Africa and a little higher in Northern Africa. But what we see is that the incidence to mortality ratio is much higher, meaning that patients are more likely to die from their cancer and get diagnosed at later stages. And we'll probably talk a little around the reasons behind that. But those are the main sort of glaring differences that we see. We do see much younger women in our population. Studies have shown that most ladies are diagnosed 10 to 15 years younger than their Western counterparts. So much younger women diagnosed at later stages and with more aggressive disease. Thanks.
Thank you for that elaborate answer. And just as a follow-up, you mentioned that 1 in 6 women, but how does it look like for men with breast cancer? As we know that men can also get breast cancer. What is that? What does the disease burden look like for men? And this is a follow-up for you, Miriam.
Thanks, Hannah. Of course, we always say who is at risk for breast cancer, and we say, do a mirror test, right? As long as you have, if you look in the mirror and you see yourself, then you know that you are at risk for cancer, especially breast cancer. So whereas men have a lower incidence of breast cancer, meaning that it comprises maybe about 1 to 5% of all breast cancers, they're still at risk. And so the message that we're trying to send out to the general public is, don't ignore stuff. Don't think that just because you're male, you can't get breast cancer. As long as you have breast or breast tissue, then you are at risk of cancer, and it's important, of breast cancer, then it's important to be vigilant. Okay. Thank you, Hannah.
Thank you. And I'll go back to Catherine. If you can talk about some of the risk factors that are associated with developing breast cancer.
Okay, thank you. Just before I do, just to add to what Miriam was saying about the trends, I think one of the highlighted or very visible trends is very advanced disease in our setting compared to the developed countries. The other trends would be the access to treatment issue. Obviously, access to treatment on the continent is not the same as in the first world. But even if you say that, within literature, when you look at the American setting itself, you will find that there will be differences within the American population, Caucasians compared to African American. So there's that socioeconomic component, which becomes even more visible in a setting of low income like ours, where infrastructure is a problem. So when we look at risk factors, and Miriam has touched already on the fact that female gender, advancing age, so we can divide them in those factors that you can change or modify, and those factors that you can't. So when you look at the gender issue, you can't change the fact that you're female. Aging, we can't change the fact that we're growing older. Then there'll be hormonal issues in a woman. So we'll say those that start having their Ps early and stop having the period very late in life. So early menarche, late menopause will be exposed a lot to estrogen in their lifetime, and they do have a higher risk in developing breast cancer. The other issues are genetic factors, but when you look at the percentage of cancers that are related or hereditary, they're really much smaller. So your 80% of all cases will be what we call sporadic. There's a whole constellation of different factors that lead to an individual developing cancer. So what other factors can we modify? And that's the important thing when we're talking about issues of cancer and breast cancer in particular. So obesity, the family planning thing, they'll say if you've never had a child, how long you breastfeed your child, because sometimes this can be protective, so you can do something about that. Being active, exercise, not leading a sedentary lifestyle. So most of the modifiable risk factors for breast cancer actually do cross over into other non-communicable diseases. So your diabetes, hypertension. So there's a whole lot of things that people will have to do: exercise, go out more, live a healthy lifestyle, eat healthy, and that is going to help with risk reduction for breast cancer. So I don't know if Miriam, you've got anything else you'd like to add? Thank you, Hannah.
Yeah, maybe we can just, thanks, Catherine. That's an excellent, I think, summary of the risk factors. And I think the clear distinction is around the factors that one can modify and do something about versus the factors that one can't do anything about. And perhaps a practical guide to, we say diet and exercise, but what exactly do we mean by that? If we look at the World Health recommendations around exercise, the WHO recommendations is 30 minutes of cardio 3 times a week. Now, I can tell you for free that very few of us are actually achieving that. And so we say how you adjust some of these lifestyle modifications is 2 things. We say small, consistent changes actually go a long way. So you're not going to wake up and, say from this day forward, I'm going to be in the, I'm going to the gym 3 times a week. You may do that for 1 or 2 weeks, and then your body will start to say, I don't know what your plans are, but as for me in this house. So we say small, consistent changes. Try and see if you can start off small, but find something you like to do. Some people like to skip, some people like to swim, some people like to go to the gym, bless them. Some people like to do aerobics. So find something that's consistent and that you can do and tell yourself, I can do at least half an hour once a week, and do that consistently for 3 to 4 months, and then try and increase that gradually to at least twice a week, and maybe maintain that for another 8 to 12 months, and then gradually see if you're able to build that into 3 times a week as the cardio says, as the recommendations are. In terms of diet, we say if you're looking at an 8-inch plate, at least half the plate needs to be vegetables, right? And if we're saying half the plate is vegetable, you could have them either raw, or we say if you're going to cook them, then look at what are your food preparation methods like. There is no benefit if you're going to torture, the vegetables on the stove for 2 hours and expect, any nutritional value, right? And so you can look at methods like blanching, where you put them into hot, salty water for about 10 minutes and then quickly stir fry them. We say a quarter of the plate needs to be carbohydrates. And by the way, this is an 8-inch plate, right? Because sometimes we talk to people and they come up with these 12, 15-inch plates and you're like, no, man, 8 inches, 8 inches.
That's too big.
So,
yeah.
Exactly. And so a quarter of the plate needs to be carbohydrates. And we say try and have foods that have what they call a low glycemic index. Glycemia is just Latin for sugar. And so foods that typically give you a high glycemic index, I always say, is everything good in this world, which is basically the cakes, the pizzas, the donuts and stuff.
Yeah.
what happens is these foods give you a high sugar, and then the body produces a high insulin, which is the hormone that produces sugar. And that if you don't have, I mean, that is involved with sugar digestion. And so if you don't have it, you get diabetes. But so high sugar, high insulin, your sugar levels drop really rapidly. And so you're wondering, dude, I just had 4 slices of pizza like 2 hours ago. Why am I hungry again? And so we're saying if you take foods that have a low glycemic index, meaning they have more complex carbohydrates, the sugars are, broken down over a period of time. And these tend to give you a more consistent sugar level. And so we say, as a general guide, less processed foods, more of the whole wheat. If you're if you're looking at flours, you're looking at more of the whole wheat flour, more of the brown pap or ugali or whatever you call it. But again, similar to the exercise, these are things that you're not going to wake up one morning and say, from this day forward, all the chapatis or all the naan in my house is going to be brown. There'll be protests, right? So it's, again, lifestyle, gradually trying to incorporate more of these healthier options. And it doesn't mean that you can't have, it's somebody's birthday, you can't have a slice of cake. No, as long as you're consistently having healthier options, then that should be fine. And then just as far as the rest of the, just to close the loop on the diet, the proteins, we say there's very good sources of plant protein that we sometimes ignore, the peas, the beans, the legumes. And then there's also very good sources of animal protein. We say we tend to lean more towards the white meats, which is basically fish and chicken, but it doesn't mean that you can't have red meat. We say if you're going to have red meat, try and limit it to 2 to 3 portions a week, and then try and ensure that it's lean red meat, just because of some of the concerns, especially with the fat and the interaction with carbonated compounds. And so, as Catherine was saying, these are the 2 things that consistently do help you to modify your risk of cancers. And again, they do, as Catherine was saying, extend into the realm of, because not only do you decrease your risk of cancer, you also decrease your risk of other non-communicable diseases. We're talking about cancer today, but keep in mind the #1 killer internationally is still cardiovascular disease. So you're basically killing 2 birds with 1 stone. You're modifying your risk of cancer, but you're also modifying your risk of these other complex diseases. Thank you.
Thank you for that. So what I'm getting is that let's focus on the modifiable risk factors and see ways we can change our lifestyles so that we can reduce the risk. And I just want to bring you back to the non-modifiable risk factors, because now we know what do we need to do for the modifiable. But for example, there's a lot of conversation happening right now with regards to genetics everywhere in the scientific field and even in our communities about what role genetics plays in increasing our risk for disease. And I know, Catherine, you had spoken about how genetics contributes to breast cancer, but could you elaborate more for perhaps people who have people in their family who've been diagnosed with breast cancer? How does that increase your risk of breast cancer?
Okay, so there are certain genes, and in breast cancer, the ones that have been really well studied are the BRCA genes, 1 and 2, that lead to individuals in a family setting. So you have first-degree relatives, a mom, an aunt, a sister, very close relatives that have breast cancer. So in terms of the how, everything is at that level of the cell, as I alluded to, not considering our discussion, I'm trying not to go too much into the issues of biology, genetics, because in my clinic I always have the same question with us. So if my mother had breast cancer, does it mean that I will have breast cancer? So in those instances, the trend definitely in the first world would be that you would have to have yourself checked. You would have to have consult with a geneticist, so that if you are found to be carrying that gene, that predisposes you to developing breast cancer. And in those instances, they can do something about the prevention. Because I think, I'm not sure what Miriam's experience is. She'll attest to the fact that there's a lot of fear and confusion. When you look at the treatment, I think in the West, there's a trend I've read of women not even wanting to have breast conserving therapies. You found cancer in this breast, please take out the other breast. If you remember a couple of years, could be 5 years ago or less than that, the Angelina Jolie effect. Angelina Jolie, very famous actress, was found to have a risk, like 83% chance of developing breast cancer, right? So she had a double mastectomy. She had, I think, an oophorectomy, removal of the ovaries. But those are there are fewer when you look at the majority of breast cancers that are not directly linked to those particular genes. And then the web or the story becomes even more complex because breast cancer cannot be thought of as this single entity. It's such a diverse group of diseases with particular genetic makeup, because eventually in the whole study of the disease, they found these other genes that interplay. So if I'm to simplify, there's a mutation, there's a cell dividing abnormally, and this cell becomes a lump and you have the cancer. But there are certain types of cancer. There are about 4 molecular classes of breast cancer itself. Within the classes, the genetic makeup will be different. And that's what makes the whole, and we might touch on that when we continue with this discussion, the whole management of this disease difficult. And if we think of that, how many countries on the continent have the ability to even just have these tests done so that if my client is before me, I can properly give them the prognosis based on all this information. So when it comes to issues of genetics, yes, we do say, yeah, you can have this BRCA gene mutation, but I think even the fact that if you look at the differences between Caucasians and Africans and other races, there's that racial component in itself. You know, you have your Africans, definitely, we are practicing like in Zambia. I'm sure the picture will be similar in Kenya as well. You have patients as young as 22 years old with breast cancer. So how does that, how do we explain that? Unfortunately, we don't have a lot of evidence gathered for a whole lot of reasons, but just so that the people listening in understand that it is really a complex disease, but we need to work together to understanding it. There's opportunities for doing scientific research and just getting to the bottom of what this problem is so that we can improve ultimately the outcomes. Most reasons, like we said, are what we refer to in medicine as sporadic. It could be a whole combination of what we have said, no genetic predisposition from the family perspective, and the patient comes and the client comes and they're asking you, why have they developed breast cancer? So you say, well, you're female, well, you know, who knows, something in the environment, it could be. So there's an interplay of a whole lot of factors that lead to breast cancer. Miriam?
Yeah, I think just to reiterate what Catherine has said, and she's given an excellent overview of that. I mean, the majority of cancers are what you call sporadic, meaning there isn't necessarily going to be a family risk. And so what we have to understand sometimes, especially as far as risk is concerned, is risk doesn't mean that you will get the cancer. And not having a risk doesn't mean you won't get the cancer either, because quite a number of people say, oh, you know, I didn't come because, you know, nobody has it in our family, so it couldn't possibly happen to me. I think that's the first message that we do need to reiterate, that we're all at risk, and the risk might vary for sure. As Catherine has alluded to, patients who have a higher risk would have maybe 1 or 2 or perhaps quite a number of first-degree relatives in their families. Like if you look at Angelina Jolie's example, for instance, her mother had cancer, her aunties had cancer, both breast and ovarian. And so for her, we would put her in a slightly higher risk. And of course, there is the BRCA gene that Catherine has alluded to, but there's probably a lot more complex genes, and the interplay of this are still, I would say, pretty nascent. Our understanding is pretty nascent in our setup, because we haven't fully explored what risk looks like in sub-Saharan Africa. And again, Africa is not a country. If you look at it from an anthropological setting, there's so many different gene lines and pools, and so just getting a deeper understanding around that is pretty much this is basically what we're attempting to do, where there's several ongoing studies that are trying to answer some of these questions. In terms of what to do if you're high risk, again, what we've tried to do is, if you go in and see your clinician, there are some quick online tools to sort of try and identify your risk. But then again, these also haven't been, fully validated in the African populations. But what we tend to do, especially if we define somebody as high risk in our population, then what we do is we have a more frequent follow-up, whereas for the general average risk, you would have people coming in maybe once a year. But for patients who we have, who we consider high risk, we would at least come in twice a year. And then depending on the resources, then we're more likely to offer them a more intensive sort of screening program.
Thank you for that.
Thank you.
I think you, Catherine, you've also just touched a bit on getting checked, which will bring me to the next topic of symptoms and screening. But before we get to that, you've both also just mentioned how breast cancer is occurring in a younger population in Africa. Do you perhaps have any insights as to why that may be? Because I also understand that it's similar to a number of other cancers as well, where we are seeing a younger patient population, specifically in Africa. Miriam, would you touch on that?
Yeah, I would say studies are still ongoing because nobody quite knows. Of course, there's several arguments, meaning that by extension, we in sub-Saharan Africa, we generally have a much younger population, and if you sort of age adjust, meaning you try and sort of follow a similar pattern or try and match it to Western populations, then the argument is that the trends are still the same. But it doesn't fully explain why we're seeing more and more younger patients with more aggressive disease. There have been a couple of hypotheses, meaning that, but one that we are having, I think Catherine alluded to this earlier, the westernization of lifestyle, where we're becoming more sedentary, we are, exercising less. And again, one of the other things that they're saying is, again, we are, as a continent, living longer, right? But you see, all these factors are basically an accumulation of insults, right? That would occur over a period of time that would, in theory, increase your risk. So it doesn't fully explain why you're getting this 20-year-old, this 30-year-old with this particular cancers developing. And then even the protective factors that we have known traditionally. When we were in school, we were told, having your first baby before 30, having multiple children, having breastfed, were all considered protective factors. But if you look at the patients coming into our clinics, and Catherine will probably say the same, they're all young, most of them have had their children before 30, they have multiple children who they've all breastfed. So we're basically being forced to throw out everything we've known about this and actually go to the ground and try and do some of these studies. There's several ongoing studies on the continent trying to look at risk factors, case controls, and also the genomics of what is driving cancers in our population. Thank you.
Thank you. Catherine, do you have anything to add to that?
I think Miriam has summarized that very well. But as we were talking, I don't know about Miriam's experience. I've had clients ask, can you prevent breast cancer? That's a very big question that people ask, because at the end of the day, when you compare to infection-mediated cancers like cervical cancer, where we know what the cause is, where we know there's a vaccine that exists, where we know there can be primary prevention, secondary prevention. For breast cancer, unfortunately, it is not a preventable disease. That's why it's very important to have this discussion we're having about detecting the cancer early. Well, maybe preventable in your genetic group of your 10% that can have prophylactic mastectomies, but generally for the masses, we need to be able to find the cancer very early so that it is treated and the outcomes are better. We can reduce the risk, but we may not in the sense of the word that if I do A, then the cancer will never occur throughout the rest of my life. So I don't know what experience you have, Miriam, even just from your clinical perspective. And this is one aspect that I find my clients have a lot of difficulties with when they ask about the cancer itself and whether it's preventable or not.
Yeah, and that's a very important point, Catherine, you've raised around we're all at risk, because there's nothing you would say you would do that would absolutely prevent the breast cancer from developing. And that's why there's importance, and it's important to have the regular checkups. Yes, you can try and modify your risk. And again, but it doesn't necessarily mean that you're 100% going to prevent the cancers, because sometimes, again, it's the same discussion we're having in the clinic, Catherine, because somebody's coming in and they're like, why am I having this cancer? I've been eating right, I work out every day, I have no family history, why did this happen? And people are looking for answers. And the reality is that there are no answers. Nobody actually knows. The reality is, as we said, and as Catherine alluded to earlier, cells are pretty much like us, right? They're born, they go through teenagehood, they stress their parents, they grow much older, become responsible citizens and members of society. They grow older, and then they're told, okay, guys, thank you for your services, and they're retired, right? Now, that's what happens with a normal cell. And the only difference between a cancerous cell and a regular cell is that the cancerous cell has escaped the normal control mechanisms of the body, meaning that unlike the cells that are being retired, these ones keep on growing and growing and growing and become immortal. But what causes that switch? Nobody knows. And because nobody knows and nobody fully understands what is it that sort of triggers that, the only thing we can do in terms of our strategies is through screening and early detection and just regular checkups that actually help to sort of keep you on top of your game in terms of detecting and managing these cancers. Thanks.
Thank you for that. And just a reminder to our participants to make use of our Q&A platform if you have any question for our panelists, and for anyone joining us via the Facebook Live to also use the comment section to ask any questions to our panelists. And thank you for bringing the issue of screening, which brings me to the next topic, which is what are the symptoms of breast cancer? If you can talk about that, if we can talk about a little, what should we be looking out for in terms of breast cancer? I think I'll direct this to Miriam.
Thanks, Hannah. I think in terms of what we're looking for is, well, there's a combination. We sometimes say if you're going for regular checks, we sometimes have what you call screen detected cancers, which are tests that are cancers that are detected when you are going for your regular checkups. But the most common presentation, certainly at least in sub-Saharan Africa, of breast cancers is a painless progressive breast lump. Right. Now, we need to keep that in context, because we say 9 out of 10 lumps are not a cancer. But however, that's why and perhaps when you feel a lump, you shouldn't automatically freak out and say, OMG, I have a cancer, meaning there's 9 other things that it could potentially be, but you definitely do need to at least get checked. If you notice any new lumps or bumps, that would sort of at least should trigger an interaction with your healthcare provider. Other signs of breast cancer, you may see, and I think, sorry, I'll just circle back to the pain, because quite a number of times most people have a lump that's growing and they say because it's not hurting, it doesn't mean anything. We're saying that breast pain on its own is not necessarily a sign of breast cancer. In fact, one would almost say 80 to 90% of women at some point in their lives are going to have breast pain. That's how common it is. And that's usually just due to hormonal fluctuations and stuff. So pain on its own is not a common symptom of breast cancer. But a lump, sometimes you may have nipple discharge. Again, we do need to make the distinction between a discharge and a secretion. A secretion is what you go checking for, whereas a discharge is what comes out on its own. And what is particularly of concern to us is there's quite a number of things that cause nipple discharge, and sometimes you can have a clear discharge coming from both breasts, which might be what we consider physiological or normal. But what concerns us is a spontaneous, meaning it's coming out on its own, unilateral, meaning it's coming out on the one side, and frequently bloody discharge. However, if you do have a discharge, meaning something's coming out without you, checking or whatever, and you wake up and maybe you find your bra, your nightgown or whatever is soaked, then that would be an indication to at least go and seek medical attention. More advanced signs of cancers would be, you might see what we call nipple changes or skin changes. You may sort of see the skin changing and maybe looking almost swollen or almost like an orange peel appearance, what they call a peau d'orange. Or you may see pulling, or you may see what we call nipple retraction, meaning that the nipple position or shape has changed. You may find that some people do have what we call inverted or retractile nipples, meaning that the nipples are on the inside and that's something they're born with. We're not talking about that. Or sometimes people have retractile nipples that sort of are pulled in a little, and then when it's warm or whatever, they may come out. We're talking about you've had your nipple one way and then it suddenly starts to change shape or whatever. Those would be indications for you to seek medical attention. Thanks.
Thank you for that. Catherine, do you have anything to add? And also, would you talk about the importance of breast self-examination? If you can also elaborate on how often it should be done, when to go see your doctor for a breast exam.
Okay, thank you. So the best person who knows themselves is the person. So when we're discussing issues of self-breast exam, I think Miriam will add later because I listened to their webinar on Tuesday. Miriam, I'm going to put you on the spot. Your guidelines were quite good and well laid out. If you look at your adolescents and younger, because I'm sure even Miriam in their practice, they see a lot of girls of high school growing age who come and they're complaining of a lump in the breast. And Miriam has said 9 out of 10 lumps in the breast are not actually cancerous. There are other growths that may occur, and those have to be determined. The surgeon has to see the client, and either they're going to remove the lump or they'll take a good history and see whether this lump is growing and waning or getting smaller with the changes in the hormonal menstrual cycle of an individual. So knowing yourself is very, very important. And I think Miriam has actually highlighted that. If you see something that is abnormal, it's you who is going to notice it. So being self-aware is very, very important. But you have to learn, sometimes I think with the knowledge and awareness as it is growing, we've got a lot of anxiety issues that are surrounding the education or the information that we're sharing. So anyone now who has anything, we want them to go to their healthcare provider to be seen and to be examined. So know your breasts. They'll change with the menstrual cycle. So if you are very aware of your normal, because normal is different for different individuals, then you'll be able to pick up abnormal. We don't have obviously slides or videos to demonstrate, but you stand in front of the mirror, you look at the position of your breasts. Are they in the same line? Obviously never, they're not symmetrical like 100%. One will be slightly lower than the other. Lift your hands up, see whether there's any lagging or of one or both breasts. Then you feel with, if one hand feels the opposite breast, and you have to go through the surface, the whole surface of the breast. Now, breasts are lumpy, bumpy organs, right? So it comes with beginning to appreciate. Never try to examine your breast just before your menses, because you're going to have, swelling and hardening, and you're not going to feel anything. A week to two after your periods is the best time, and consistently about the same time for you that you check your breast. In the shower is a good place. If you're having a shower, you're having your bath. For older women, those who have partners or significant others, husbands, sometimes they say that a partner can actually be the one to feel and notice a lump. From experience, the scare, if today I'm fine, I go to bed at night, tomorrow I wake up and I feel a lump in my breast, cysts, these sac, fluid-filled sacs that in the breast are common and probably more common than I thought. And the whole process of you wake up and there's this thing that wasn't there will drive you crazy, will drive you nuts, because all you're thinking about is, oh, I've got breast cancer, I've got breast cancer. But you can only know for sure if you have breast cancer if a tissue has been taken out of whatever is in the breast, right? Whether it's a fluid on a microscope, they've seen abnormal cells, or a tissue, and they've said, okay, this is a confirmation. So examining your own breast is good. You can do it not every day, obviously. Once a month would be adequate, depending on the age. And a clinical breast exam is what your healthcare provider is going to be able to do. And maybe Miriam, you make a comment, because I was very fascinated by the study that you alluded to, where even healthcare providers do not know how to examine a breast. So maybe Miriam can comment on that. But generally, healthcare providers, whether a nurse, a clinical officer, or the lower level healthcare workers in the lower level, is because we're going into the issues of rural versus urban communities within the context of the referral system in our healthcare, most African healthcare systems. So a clinical breast exam is something that should be done by a healthcare provider. I think this can be done depending again on the risk, and that's what Miriam was highlighting. We have to know your risk category. If you're at a higher risk, you may need to be seen more often, but if you're not of that high risk, once a year might be adequate. The other question is X-ray of the breast. A lot of people hear about mammography. So that's simply X-ray of the breast. In Africa, I've seen a trend about the age, when should a person have their first mammogram? In our local setting for Zambia, we've set the age at 40. Age 40, you should have your first mammogram. And I think for a lot of African countries, that may be true because of the younger age at which we're seeing patients with breast cancer. That can be done again based on whether someone falls in the low, intermediate, or high risk category for developing breast cancer. But yearly might be enough. But I've had clients who in between screening mammographies have developed breast cancer. And that's what we're trying to avoid. So in terms of how often, I think it's usually quite dependent on the country's policies and what the country has put in place in terms of their cancer control plans. So we in Zambia do it yearly. So we advise for our clients to do it yearly. It's opportunistic in nature, meaning that we don't phone you up and say, hey, you didn't come for your mammogram this year, please come. So we encourage women. So we don't have like a population-based type of screening where, like, if you compare to your Australia, the UK and other first world countries, they will call you up, right? They will call you up to go and be checked. But we unfortunately do not have the capacity or the resources to do population-based screening. But we do encourage women and integration of these services within existing systems so that we are not missing out on that group of people that we can see. So Miriam, I said I'd put you on the on the spot because you've done quite a lot in this, and I was quite fascinated hearing from you. So maybe you should add something.
No. Thanks, Catherine. I would say thanks for the overview of the self-breast exam. And as we said, as Catherine is saying, the self-breast exam is generally as part of the larger breast awareness strategy about knowing your breasts and being aware of changes and making sure that you don't ignore stuff. I think a great summary of, the steps that Catherine has clearly elucidated is basically look, move, and feel. The only thing that I would add, especially if you're doing the breast exam, is that the self-breast exam is that, as Catherine pointed out, breast tissue is very nodular. And so, as you probably noticed, and Catherine's mentioned, like from mid-cycle to just before your period, the breast tissue is enlarging. And if you think about it, it's almost like having a cup, putting a sponge in it, and then adding water to the sponge. So the sponge is doing that, but the cup remains the same. And that's generally the most common cause of breast pain or discomfort, especially as you're getting towards your period, but it also feels that the breast tissue is quite lumpy. Now, the best timing is, as Catherine says, about 1 or 2 weeks after your period, when, the sponge is sort of shrunk back and everything sort of squeezed out. But the trick is that not to use the tips, because if you feel with the tips, then you're invariably going to be thinking, OMG, I'm full of lumps, right? The best way to do it is to use the pads of your 3 fingers, and you can use them, almost think of them like a spatula. And what you're doing is you're gently pressing down the breast tissue against the chest wall, because what happens is the breast tissue is compressible. It's like a sponge. So when you press down, when you feel with your tips, it might feel that like there's something, but when you press down, the breast tissue goes down. If there is a lump, because it's a different consistency, then it almost feels like a marble against your hand, and it stays up when the rest of the breast tissue is going down. So that's just the only thing I would probably add as far as the self-breast exam is. And as Catherine, eloquently elucidated, the best guide of what's going on with you is obviously yourself. I mean, it's fine for us to tell you, come in once a year, have a clinical breast exam, but from one year to the next, the best guide of what's going on with you is, yourself. And in terms of clinical breast exam, the study Catherine had alluded to, and we said there is a real need to integrate some of these services, both at a primary healthcare setting, such that, a lady coming in for, say, family planning or an antenatal clinic has an opportunity to discuss breast awareness, have a clinical breast exam. What we were doing was, in recognition of the fact that we do want more of our health workers empowered to teach our ladies in order to empower them to take charge of their health, we tried to look at what was the knowledge, skills, and knowledge and skills around clinical breast exam. Now, as Catherine explained, the self-breast exam is what you do for yourself. A clinical breast exam is what the health worker, either a nurse, clinician, clinical officer, is going to do for you. And so what we found was that most of the health workers knew the risk factors, but when it came to doing the actual exam, then we noticed that there was quite a discrepancy, meaning that they didn't have the skills to do a proper clinical breast exam. However, after we put them through a training program, and we were able to get their, skill sets up by almost a 40%, 50% increase. And so as part of the national strategies, even as we look towards, decentralizing some of these services, we actually do need to ensure that the people providing these skills are empowered to do so. In terms of our screening strategy, again, it's pretty much reflective of what Catherine is saying they're doing in Zambia. We are advocating for mammography annually from the age of 40, and this is just because our average age at diagnosis is 48 years, and this is why we are sort of trying to straddle this period where we're seeing most of our women with a median of around 45 to 55. And so as part of our national screening guidelines, we're having the annual screening up to 55. And then from 55 to about 75, we're staggering that, dropping that down a little to every 2 years from the age of 55. But similar to Catherine, again, these are just, we've just come up with this recently. The government's has had a couple of pilots to try and see how this would be, rolled out to a much broader level. They've tried to provide mammogram machines in each of the counties in the country, but it does require a lot of intensive, resources and things. And so the two strategies are going in tandem. So one is the aspirational, where, as Catherine is saying, one day we hope we'll get to where you get a letter or a text on your phone that, come in for your mammogram. But in the interim, we're, going along all these early detection strategies. But at the end of the day, I think the message that we are hopefully sending across to you is that you need to take ownership of your health, because at the end of the day, you are the primary determinants of your health-seeking behavior. Thank you.
Thank you. Thank you both. Bring up important points, especially on breast self-awareness, that, the best person who knows you is yourself. And also the importance of actually knowing how to do the breast exam yourself and equipping yourself to do it right. Miriam, I'm also going to put you on the spot because I did attend your talk on Wednesday, and you spoke about mammography and how its effect on mortality rates. So if you can also just elaborate more on that, and perhaps if there are other detection or screening tools that are available, and why mammography, like you said, you think is the best in the African context.
Yeah, so thanks, Hannah. In terms of mammography, if we look at the body of evidence, and what has happened is just because breast cancer has been very common in the West since the 50s, they've had benefits of over 70 years of studies around this, and looking at the detection and lives saved versus the risks that sometimes people think about when they think about mammography, which is basically a small X-ray. But in terms of and the evidence that exists, the gold standard for screening is currently mammography. Now, the challenge has been around questions that we get from patients typically as, okay, if it's radiation, is it maybe harmful? And should I be getting this? But if we look at the body of evidence, we've seen that all the studies that have consistently looked at mammography have been able to demonstrate almost a 40% reduction in mortality, in breast cancer mortality. And if we weigh that against the risks of radiation, because some people say, okay, I'm getting radiation, should I be worried? The whole idea is, even as we sit and speak and walk and whatever, we are getting background radiation. And so radiation is something that we are, constantly exposed to from the sun's rays and that kind of thing. But what happens is, especially with the current mammography machines, the digital mammography, you're getting a small dose of radiation, which is equivalent, one would say, of a chest X-ray, for instance. And in order for you to significantly increase your risk of, getting a cancer from mammography, you would need to get at least 10,000 mammograms, as it were. Now, if we're starting at the age of 40 and we're, God willing, living to 120, even then, you're still only going to be getting perhaps maybe at best another 50 mammograms, meaning that you would have another 9,950 that you would need to have in order for you to significantly increase your risk of radiation. But of course, so in the balance, the risk is, especially if the whole idea behind the mammogram is it's able to pick up lumps even before you feel them. Before you feel a lump, it needs to be at least a centimeter. The mammogram is able to pick up lumps that you're not necessarily able to feel and that you can actually manage appropriately. The other question comes in when ladies are, less than 40 years old and they say, hey, I want to have some form of screening. And so as Catherine had talked about earlier, the breast tissue is made up of glands, which are the ones that produce the milk, and then the ducts that then transport the milk to the nipple area, just because from an evolutionary perspective, the main function of the breast is to provide nutrition for baby. And so as we all grow older, these glands tend to shrink and disappear and get replaced with fatty tissue. And that's why you find that, especially if in your 40s, your breasts probably feel a lot softer than they did 20 years ago. And then they'll probably feel a lot softer 20 years from when you feel them. And you may notice sometimes in older ladies that the breasts even start to droop. And that's just because the total gland content is decreasing and the total fat content is increasing. And so the reason we have the cutoff at 40 is because at 40, we expect the glands have reduced to such a level that when you shine a light, you're able to see an image. If you try and shine a light in a younger breast that's full of glands, the glands just scatter the light. And so you may not necessarily be able to see anything on the mammogram. And that's why we have a cutoff at about 40. Of course, having said that, we say your breasts don't necessarily read the textbook, right? And so if you have a concern and you're less than 40, sometimes we will usually do an ultrasound, which gives us more detail in a younger breast. But sometimes if you're 40, for instance, and you still have a lot of glandular tissue, meaning your breast didn't quite get the memo, then we may sometimes also use the ultrasound to try and get a little more clarity. And certainly in the 35 to 40 group, the discussion that we've had, especially from a national sort of guideline perspective, is that if the lady is interested in a screening modality, of course, it's not really optimal because it's operator dependent, but sometimes it will recommend that they have an ultrasound as advised. Thank you.
Thank you for that. You had also previously spoken about how the incidence rates of breast cancer are very close to the mortality rates, and I guess which speaks to the fatality of the disease and also perhaps late diagnosis. So, Catherine, could you talk about the screening uptake in Africa? Is this the reason why we are seeing high mortality rates, and perhaps also elaborate more on the barriers of the screening uptake in Africa? I understand there are a lot of aspects involved in that.
Thank you. I'll refer to the ABCDO study, which was looking at disparities in outcomes for breast cancer, the African Disparity in Outcomes study. So some of the things that they highlighted were barriers to good outcomes. Is one, late diagnosis, which firstly comes from the lack of knowledge or awareness about the symptoms of breast cancer. But those that do have the knowledge, you get the cultural context. You rather go to see your traditional healer first before you've gone to, or your grandmother or your great-grandmother, in the rural setting before you actually go to a healthcare provider. There's still people that are superstitious and will believe that what they're seeing in the breast, depending on obviously the cultural context, but generally across the continent, you will have that kind of not proper understanding. So, somebody bewitched me, or, I had a baby and something happened. So there are all these myths and beliefs that are so intertwined with the cultural context that it's sometimes very difficult for those people to begin to change their health-seeking behavior. But in those that actually do appreciate, we've done quite a lot of education and awareness, and on platforms such as this, it might be just the accessibility to a facility. So they live, like if I say 10 kilometer, maybe 20 kilometer radius of the nearest first healthcare post. So there's issues that are related to poor access to services themselves. So that's within the context of the individual and their environment. But when it comes again to the healthcare system, it's lack of knowledge again within the healthcare providers. So we've had a lot of experience of people that will come and you take the history. Their symptoms are 2 years plus, and they'll tell you, I did go to see a healthcare provider, but I was told this is an abscess, or I was given antibiotics, or I was told not to worry about it. So there are these delays at the point of healthcare provision within the different levels of referral. So eventually, when this individual does come and arrive at that point of care, their disease is quite advanced. So it's a complex interaction of different issues from the individual community and the healthcare systems themselves. That's how you would classify what leads to barriers. It's hard for somebody to find the money to pay for transport to go to a facility, or sometimes if they do, if the illness or their problem has befallen them at a time when, like in Zambia right now, we're going into the rainy season. You begin to say, oh, I need to go and cultivate my land. I need to go and farm. So that becomes a non-priority for them until after the harvest. They will not turn up at a health facility. So those are some of the issues that are leading to a delayed diagnosis. On the flip side of it, what I'm beginning to notice, and I'm not sure how the experience Dr. Miriam has, is as we begin to educate, we begin to pick up early stage disease. The one Miriam was pointing out to where there's no lump, there's some microcalcifications. Then we begin to have challenges within our own system, stereotactic core biopsies. Can someone then be able to do a biopsy? So I might not have an interventional radiologist who is conversant or who has the skills to do that. So as we are looking at breast cancer awareness, early detection, everything has to be looked up at in the context of ensuring that we will have the capacity to make a diagnosis. Because what's the point of someone coming, they have microcalcifications, and then I'm like, oh, I can't do a core biopsy. Then I'm not sure what they have. Is it breast cancer? Obviously, I'm sure Dr. Miriam wouldn't want to go out and do a mastectomy if she doesn't know that this individual has breast cancer. So I've just begun to see a change now as we are having even more challenges managing very early stage disease, and it's at that level of diagnosis. So we need to grow capacity within the healthcare personnel across disciplines, surgical, radiology, radiation oncology, medical oncologists or clinical oncologists, so that we are beginning to offer a more comprehensive multidisciplinary team in terms of addressing the issues. Miriam, you've got anything to add?
Yeah, no, I mean, just to underscore your comments around, I strongly feel that, screening without anything supportive is actually criminal. I mean, it's not enough to say, yes, you have breast cancer, or yes, you have a lump. The question is, what's more important is what happens next. And that begs the strengthening of the entire health system from both the diagnostics, management, and survivorship concerns. The entire spectrum needs to be covered, because if we are only able to pick up and detect, and that was, I think, the situation that we were seeing in Kenya a couple of years ago, where quite a number of NGOs and were trying to raise awareness, and then at the end of it all, they were like, then what, right? And so I think people had to take a step back and say, how do we support the entire journey, and which is what the government has been trying to sort of plug into. What are the different steps in order to fully support the whole spectrum of disease? And you're right, Catherine, we're also seeing something similar in Kenya. For instance, data from our National Public Tertiary Referral Hospital had, say, 2012, had about 3/4, almost 80% of patients being diagnosed with stage 3 and stage 4, like more advanced cancers. And then just by 2018, this had dropped to about 60%. And I'm sure this is a testament, of course, to the government efforts by civil society and communities to just increase awareness. And so we're saying that 40% of our breast cancers are now early breast cancers. And so we do have to sort of think about what are the different considerations, especially for these type of, for the entire sort of spectrum. Early breast cancers may not necessarily need to lose their breast. If they have a very small lump, we can do breast conservation surgery, and they do not necessarily need to lose their breast, but they will need to have, radiotherapy. Do we have the services for that? Or if they do have a screen detected lump, as you're saying, we do need to be able to have the resources to do stereotactic or ultrasound guided core biopsies that would help to support these treatments. And of course, on the other spectrum, if you are seeing more advanced cancers, then a priority as well is that how are your palliative care services? Are we able to keep our patients pain-free and comfortable despite a diagnosis of advanced disease? Because I think the narrative, unfortunately, in Sub-Saharan for the longest time has been cancer equals death. And we're saying we need to shift that narrative and say there is treatment available irrespective of the stage that you have. Now, the goals of treatment might change. In early cancers, you're talking about not only treatment, but cure. But in more advanced cancers, they are still treatable. And of course, the burden is on us as well as health workers, because sometimes patients come in with advanced disease and they get told by the health workers, what are you doing here? Go home and die, right? And we're like, so there's clearly a need for education of ourselves and our peers and as a broader community, that cancers are treatable irrespective of the stage. The treatment goals or whatever's may change. But again, having said that, we do need to set up the infrastructure to support all those statements and care that our patients are getting. Thank you.
Thank you for that, and for raising important points relating to barriers and also access to healthcare, and touching a bit on treatment. I'm going to move to debunking some myths. I think because we have experts with us, I think it would be great to talk about some of the myths that circulate in our circles, and if you can tell us whether it's fact or myth. So I have a list with me. And the first one is, does wearing a bra cause breast cancer? And Catherine, could you address that?
So that's a myth. There is no scientific evidence to show that there's any association between bra wearing and developing breast cancer.
Okay. And
if I could just chip on to that, I think underwire bras have been getting a bit of a bad rep.
Yeah.
So everyone is saying, listen, my underwire bra caused my breast cancer. No, irrespective of whether it's a regular bra or an underwire bra, it doesn't significantly, it doesn't affect your risk. What's happening externally doesn't affect your risk. And then just similar to bras, it's some of the myths around
cell
bras
phones.
We've heard is putting money inside your bra, or putting your cell phone inside your bra. Again, that doesn't increase your risk. just a note on bras, now that we're sort of talking about it, apparently 3/4 of us are walking around wearing the wrong bra size, apparently. And sometimes having a ill-fitting bra, and sometimes people use a smaller bra to achieve a push-up effect, can sometimes cause breast pain, and that may cause a bit of concern around, listen, I'm not, I'm having pain, could it be a cancer, and sort of go down that spiral. So we do need to make sure that, one, we're wearing the correct bra, two, we're getting the correct support. Sometimes larger busted women, you're like a double D and wearing a bra that doesn't really give you any support. And how you will know is you'll usually see there's like, the bra is cutting into your shoulder straps and things. And that can also cause breast pain. But by and large, bras, putting anything near them or whatever, does not, increase your risk of breast cancer. Oh,
Thank
the other
you.
thing is sleeping in a bra. Somebody says,
Sleeping
I slept
in a bra.
therefore I got breast cancer. No, that doesn't happen.
Yeah.
Okay, great, thank you. And the second one is to you, Miriam. Does using underarm antiperspirant or deodorant cause breast cancer?
So no. So most of the antiperspirants have what you call aluminum-based compounds, and so they usually give a deposit, like the whitish layer that you sometimes see once you've sprayed or put on the roll-on. But these do not cause breast cancer. Now, sometimes if you're going to have a mammogram, especially in those over-enthusiastic appliers, you may see some film. So sometimes you'll be advised, if you're going to have your mammogram or your screening, then don't put on your deodorant. Now, some people say that, despite it not being associated with cancers, they would prefer not to have any chemicals, being applied to their bodies, and that's fine. And we say you can't use natural sort of deodorants or whatever's. Some people use dilute vinegar. Some people use witch hazel that tends to dry up the area. Some people use lemon or dilute lemon and stuff, and that's fine. All we're saying is be kind to your colleagues and your co-workers. Please don't go sweating and
we all need deodorant at some point, right?
Exactly. So please don't feel that breast cancer is a reason to stink up the office. No, there are many strategies. None of them have been linked to breast cancer. So go forth and deodorize, as it were. Yeah.
Catherine, do you have anything to add on that?
No, that's well put, especially the part about, be kind to your colleagues. That's very important. Yeah.
And I think you've already addressed it, but I'm just going to get you to debunk it as well, or call it a fact. Does breast cancer only occur in older women or postmenopausal women? Catherine?
So we've debunked that through
Yes.
our discussion.
Yes.
It can occur even in the younger women.
Yes. In the next one, I think, Miriam, you also just debunked it. Does trauma to the breast cause breast cancer?
No, trauma doesn't. The only thing sometimes trauma can cause is initially when you get a bump, you may notice a bit of swelling or redness, and it may form a little clot, what you call a hematoma. And sometimes that sort of fades away with time. But sometimes just because the breast is made up of fat, some of those fat cells can die. And you have a lump that is what you call a fat necrosis, meaning it's just an area where the breast cells have died, and that may sometimes cause a lump. But again, that lump is benign, meaning non-cancerous, and it doesn't lead to a cancer. And those are the only things that trauma would cause as far as the breast is concerned.
Yes.
Thank you.
And I think we've also debunked this one, that men can't get breast cancer. And I think you have mentioned that they can. And lastly, breast cancer always forms a lump. Catherine?
I think that also we've debunked. There are cancers that you pick up that are not associated with a lump, especially in the very early your screening detected breast cancers.
Yeah. We're going to move.
Sorry, just to interject, and sometimes you may not necessarily get a lump. The first symptom might just be a bloody nipple discharge, and you may not necessarily feel a lump. In certain cases where you have like pre-cancers, you may just get, nipple discharge, and that might be it. So we're just saying, don't ignore any new symptoms or whatever.
Yes.
Do get them checked out. Yeah.
Okay. We're going to move on to stigma now, which I think is a very important topic. Both stigma, meaning discrimination towards the patient or survivor, or stigma, meaning the negative perceptions that you can have towards your own body. To just touch on that, Miriam, about stigma with breast cancer patients or survivors.
Thanks. I think, unfortunately, stigma is still one of those, I would say, one of the more pervasive barriers to care that we don't frequently talk about. Now, we did a study in East Africa, both Kenya, Tanzania, both public and private institutions, trying to look at what ladies felt the perceptions were around stigma. And what we noticed was not only was there stigma, but also family disintegration around the diagnosis of breast cancer, where you go home and you say, honey, I have a cancer. And you're told, honey, there's a door. Don't let it hit you on the way out. But also just stigma, both from, because stigma could be perceived. Patients felt that maybe they were being talked about, but sometimes patients would say, listen, I'd be sitting in a group and they would be talking about somebody as basically a quote unquote coffin in waiting. And so they would feel, unable to disclose their diagnosis, right? And then again, also the fear around losing a breast, or the perceptions after the alteration of their body image after the breast, after their mastectomy, would also lead to stigma. But this was also, one would say, perceived, but also real, where patients were, losing their, jobs because somebody was like, they're not going to be here for long, and that kind of thing. So there's definitely so many layers in terms of intervention around stigma reduction that we need to do, both from just a patient education level, community education level, but also from policy levels, at looking at how do we protect these vulnerable women. Because we say sometimes telling a woman in sub-Saharan Africa, you have breast cancer, is not just you have cancer. It means you could lose, your family, you could lose your livelihood, you could lose your sense of self-worth. And so there's definitely a lot around efforts that we need to do around stigma, because even sometimes when the partner wants to support their husband wants to support his wife or whatever, there's still, as I said, a lot of collectivism where the decision is made by the community, and we're very strong. And I love the sense of community that we have as Africans, but sometimes it plays out negatively, because then the community says, we don't want this liability, like, can you get another wife or whatever? And so there's definitely lots of efforts that we need to do, because then again, fear and perceived anticipated stigma of losing the breast sometimes will make patients, delay to receive or seek attention, and then they only come when it's more advanced, and you definitely do sort of need to actually, have a mastectomy. And paradoxically, we're saying the earlier you come in, the more the chances of you not necessarily losing your breast. So lots of efforts around that are definitely required. And for us going in, from our studies, we sort of thought going in that perhaps this had to do maybe with the socioeconomic status, as Catherine had alluded to. But what was interesting to us, especially around as far as stigma was concerned, was irrespective of whether the patient was well educated or, in a high-end institution or in a public institution and a lower socioeconomic status, the outcome was still the same around family disintegration and stigma. So lots of efforts, I think, definitely need to be done. Thank you.
Okay, thank you for that. Catherine, do you have anything to add regarding stigma?
No, not really. I think Miriam has tackled it very, very
Okay.
well. And just to encourage everybody out there that we need to look at the complete picture. You know, the perceptions for the woman. I've had clients who will say, I'm not going to have a mastectomy over my dead body, literally, you know, because of the perceptions. So thank you, Miriam. I couldn't have said it better. So only that we need to do a lot more to address the issue of stigma as a barrier to treatment and care, as Miriam has alluded. Yeah.
And we're just going to move to treatment. I know we've lightly touched on it, but Dr. Mutebi, if you can talk about treatment options, and Catherine, then you can also talk about metastasis and advanced cancers.
Thanks, Hannah. So the mainstay of early breast cancers is surgery. And so with early breast cancers, as far as surgery is concerned, you do have a couple of options, especially if the tumor is very early, at a very, very small, in a single area. We can do what we call breast conservation surgery, which means that we can just remove the area of the cancer along with a margin of normal tissue. And then do subsequent what we call radiotherapy, meaning we would send them to Catherine. And this is equivalent to doing a mastectomy where you remove the entire breast. Now, as far as the breast conservation therapy, it's actually called therapy, not surgery, because it involves radiotherapy. The equivalence is only with the radiotherapy. It's the lumpectomy, meaning you remove the lump plus radiotherapy, or having a mastectomy. And so these two treatments are comparable. But if you remove just the lump and say, and I'm bringing this up because quite a number of people who get referrals where somebody just had the lump and they're told your cancer is cured. No, that's not correct. You do need to have the surgery plus the radiotherapy in order to have the similar outcome to somebody who's had a mastectomy. Part of the, and this is in patients who just have a single area that has a tumor. Now, you could still have an early cancer, but have multiple, like little areas of cancer throughout the breast. And in that case, it's not necessarily safe to have a lumpectomy, meaning that because if you just remove one area, it means you would still leave all these other areas of tumor behind. And so the safer thing to do would be what we call a mastectomy, meaning remove the entire breast. But especially if you have an early cancer, you can have what we call an immediate reconstruction. And a reconstruction could be either using your own body tissue, what we call an autologous reconstruction, or we could use an implant-based reconstruction. So with the autologous reconstruction, what we do, if you think about it, Hannah, it's like coring out an apple. We preserve the skin envelope, and we take out all the tissue underlying that has the cancer. And then we take tissue either from your back or from your tummy, which sometimes ladies love because they get a tummy tuck at the same sitting. And we use it to create a new breast. So you go to sleep with a breast and wake up with a new breast. And so those are some of the options for early cancers. For more late cancers, and Catherine will probably talk about this, depending on the setting, sometimes patients may still not want to lose their breast. And so sometimes we give them chemotherapy upfront to try and shrink the tumor. And in select cases, we can do breast conservation in this setting, although more often than not, we end up doing a mastectomy, which is removing the entire breast. Even for more advanced cancers that are curable, sometimes we end up doing what we call a delayed reconstruction, meaning you have your mastectomy initially, and then maybe 1 or 2 years down the line, then we go ahead and do your reconstructive surgery. There's a very limited role for surgery in what we call metastatic disease, and Catherine will talk about this a little. And this is only more for quality of life, or ensuring maybe you have a big tumor that's, that's maybe taken over the breast. It's maybe there's a wound or there's a whatever that's very uncomfortable. Then sometimes it will take you to theater, just have that removed, get you some skin cover either from the tissue or the whatever's around, and just make sure that at least your care that you're getting is comfortable. But that's generally, one would broadly say, the spectrum of treatments as far as surgical care is concerned in early and more advanced breast cancers. Thank you.
Yeah, so thank you, Miriam, for that. We could spend another hour just talking about treatment options for breast cancers and what the challenges are when you are discussing this. So for the very first, I'll talk about systemic treatment. At the beginning of the definition, we said breast cancer is not a singular disease, and it is a systemic disease. I say it's systemic because regardless of the size of the tumor in the breast, dependent on the biology of the breast cancer type that an individual has, they may need some kind of systemic treatment, either chemotherapy or hormonotherapy, to address those little cancer cells that escape the primary site and go through the blood to other areas. So the challenges I think we have within the context of systemic treatment in low middle income setting is, first of all, the classification itself from the diagnostic perspective, so that I'm able to confidently say what type of systemic treatment an individual needs, right? So I'll need to know the class of the cancer they have. Hormone sensitive, that or the one that does not exhibit any receptors to hormones. So just looking at that component itself, we may be able to say, okay, you can do without chemotherapy, or we can only give you hormonotherapy, or you need a combination of different things. You need chemo, then you need to be on hormonotherapy for quite a long time. And the other methods, core to breast cancer management, Miriam rightly put it, is surgery. We've had patients who in the neoadjuvant setting, meaning we want to give systemic treatment to reduce the mass so that those surgeries that Miriam is alluding to can be done. And the person has, let's say, the complete melting of whatever lump they had, then they feel that I'm done, I'm cured. Without surgery, the potential to cure breast cancer is really quite minimal. Surgery is core to controlling the disease, whether this be removal of the whole breast or part of the breast where the lump was, which if you do breast conservation, and Miriam rightly put it, you need to have radiotherapy, because studies have shown that if you give radiotherapy to those that have had breast conserving treatments, the risk of the cancer coming back locally is reduced markedly than if you don't do anything. Now, access to radiotherapy on the continent, I'm sure we are aware, is not very good. I think there are about 28, if not 30, African countries without radiotherapy facilities. Those that have radiotherapy facilities may not necessarily have the type of equipment that is of a technological type for me to be able to treat, especially in the breast conserving therapy arena, that I may not necessarily be able to deliver that radiotherapy in a way that is recommended. So there are challenges because radiotherapy equipment is expensive, the techniques of treatment are varied, and it's one of those fields where I always compare it to smartphones. You know, you've got your iPhone, I don't know, iPhone 11 or something coming up with different software. So from the perspective of sustainability, accessibility to radiotherapy, governments obviously are investing, and it is not a cheap sort of investment. So sometimes, especially in our practice locally, we've ended up advising our clients to do, let's say, a mastectomy, even though I know they could have had a breast conservation treatment. Because for those that have early stage disease, if you do a mastectomy plus your systemic treatment, depending on what you find, they may not need to receive radiotherapy. So just from the technical issues of delivering the radiation. Then the other method, when we're talking about systemic treatments, I've talked about chemotherapy. Obviously, these are medicines that are injected through the veins, and they literally, in layman's term, when we're explaining, we say they kill cancer cells, and they do have their own downside of side effects, but the benefit of giving chemo, according to the different studies, obviously outweighs the risk. Now, when we start looking at the types of these systemic treatments, I haven't even talked about targeted therapies. You've heard of Herceptin, I'm sure, especially when Herceptin was first studied and came on the market. Who pays for this treatment? You know, big pharma, very expensive drugs. So we begin to layer them or tier them into first, second, third line type of chemo agents. You go to your targeted treatments. Again, there are so many generations of these types of drugs that have been developed. And unfortunately, for the continent, we do not have access to even newer drugs, because what works in metastatic disease setting to prolong life and have a good quality of life is really very effective systemic treatments, whether this be immune therapy, whether this be chemotherapy or hormonal therapy, which unfortunately for our setting has been a challenge. The system here in Zambia is that the government bears the cost of treatment, but financing for cancer care is something that is also a big topic that different countries are trying to do things differently for. Even your insurance, sometimes where you have medical insurance, might not cover a newer drug. We are, in a sense, also disadvantaged because we have very few clinical trials currently ongoing in our setting, because that might be an option for somebody that has stage 4 disease to say, okay, let's put you on this trial drug and we'll improve your outcome or quality of life based on that. Yeah, so that's what I would say. Basically, Miriam is correct. And surgeons and oncologists, first of all, we are a team. People must realize that no one specialty can control breast cancer, right? You need everyone. You need your radiologist, you need your surgeon, you need your palliative care team, because we are looking at an individual holistically. So in the palliative setting, the other indications for surgery might be if someone has a pathologic fracture, for instance, we are trying to keep them to be moving and not be immobile. So let's say an orthopedic surgeon may need to go and do a hip replacement as an example, just for the purpose of improving quality of life. But to not forget, and Miriam said this, do not think that we cannot treat breast cancer. Breast cancer can be treated at any stage. It's the goal that changes. It's the aim that changes. Am I treating to achieve a cure, or am I treating to improve quality of life? Yeah, so for the sake of time, obviously, unless there's anything else for clarifying, I'll end here.
Thank you so much. That's very elaborate and very important. We have a question in our Q&A. The question is, with an autologous reconstructive surgery, would the woman still be able to breastfeed if needed?
Thanks for the question. With the autologous, I mean, we're still doing a mastectomy. So we are removing all the ductal tissue, and sometimes depending on the stage, we may do what we call a skin sparing, meaning that we try and preserve as much of the skin envelope, or we may do a nipple sparing, depending on certain criteria, where we just remove all the underlying breast tissue. But because you've removed the glands and the ducts, and those are not necessarily connected to the new tissue that you're bringing, then you may not necessarily be able to breastfeed from that, from that particular breast. But you do raise a good point, especially with younger patients who we see on our clinics. And as Catherine has alluded to, it's important to have that multidisciplinary discussion and stuff, because even when, depending on if we're seeing, like, for instance, a younger patient who's come in and who has this concern, she probably has never had a child and would maybe like to, once we're saying, God willing, she completes her treatment and we successfully rehabilitate her. It's important to discuss these fertility concerns upfront. And I mean, they may not necessarily be readily available, but I find that sometimes patients actually benefit from having that discussion. Sometimes, depending on the resources that are available, patients can be counseled on things like cryopreservation. As I said, those are few and far in between and fairly costly. But even in terms of the treatment regimes that Catherine has alluded to, if fertility is a real consideration in mind, then we can give more fertility preserving regimes that are able to at least improve ovarian function once the patient has been on their treatment, say for a couple of, completed their chemo and maybe hormonal therapy for at least 5 years or so. But those are, as I said, that's still part of the holistic approach that you would need to sort of have with the patient upfront and manage their expectations around what to expect, what not to expect. Thank you.
Thank you. We are now wrapping up, but before we do, we just have some terms that you have used throughout this presentation, or that our audience might have heard from their doctors, or just wherever they are, that I think it would be good for you to define so that we know what they mean. And the first one is benign. Catherine.
I actually thought the surgeon, Miriam, was going to answer that. So something that is not cancerous. Yeah,
Okay.
by definition, benign. So the other word we use a lot is malignant.
Yes.
So yeah, so when you say malignant, it's cancerous. And just to share, recently one of my clients actually almost what's the word she used? Like, you can't say that, doctor. You're not supposed to tell me. We're discussing. Unfortunately, the cancer is recurrent. She's young, and she needs to understand that she now has stage 4 disease. And the terms I was using, like, oh, you're progressing. No, you can't say I'm progressing, but she doesn't understand she's recurrent. So it's a good thing that we need to clarify these things. To a point where we've not now sent our clients into panic. Yeah, so benign is just something we say is not cancerous, and a cancerous thing we call malignant. And tumor sometimes is another word we use. So tumor, strictly speaking, is a growth. So yeah, it could be benign or it could be malignant. So I hope that has clarified that.
Thank you. And we have fibroadenoma, Miriam.
Simply speaking, I would say fibroadenoma is what we would call an overgrowth of normal breast tissue. Keep in mind, we've talked a little about how the breast tissue is made up of glands and ducts, and how breast tissue is very hormone sensitive and has those monthly variations. Now, what tends to happen, especially with fibroadenomas, is that areas of the breast are more sensitive to the hormones than others. And so these grow faster than the surrounding breast tissue and form what we call fibroadenomas. Now, the thing about fibroadenomas is these are the most common lumps we see within the reproductive period, which is anywhere from about 15 all the way up to when you get into menopause, 55, 45, depending on, but again, most commonly, especially around the earlier phase, most likely ladies in their teens and early 20s. And so the thing with fibroadenomas is we say they can do one of 4 things. They can grow bigger, smaller, stay the same, or disappear entirely. So again, not all fibroadenomas need surgery, and most of the fibroadenomas, because we know they can disappear on their own, once they have been evaluated through what we call a triple evaluation, meaning they've had a clinical exam, they've had some form of imaging, some form of biopsy done, then most of the time these tend to be followed up for most young ladies, and they successfully get resolved. So fibroadenomas are not a sign of a hormonal imbalance, because some people sort of say, oh my God, I have a fibroadenoma, my hormones are imbalanced. No, if your hormones are normal, then you'll be getting a regular period, but it's just a hypersensitivity. For instance, the way some more people are more sensitive to dust or cold. But if you've had one lump, then you're more likely than somebody else who hasn't to have others. And that's why it's important to have regular follow-up, especially with these kind of lumps. Thank you.
Thank you. And Catherine, could you define early detection and late presentation?
So we have discussed quite a bit about the screening, and in early detection, it's all the effort that we're putting into catching a cancer early. So it will involve awareness, being examined by a professional, and having a diagnosis made, especially for those that have symptoms, so that they have a biopsy and we then can treat what we find, right? So late presentation. So left untreated, the natural history of a breast cancer is that it will grow. Time may vary dependent on how aggressive this cancer is, from a couple of months to many years. We've had quite a number of people who come with a very long history, but left untreated, breast cancer will grow. It will become bigger, it will spread. But we didn't talk about how the cancer spreads. It can spread through the lymph vessels into the glands in the underarms, in the neck. It can spread through the blood to other organs, mainly the brain, the lungs, the liver, the bones. These are the main ones, but even in the bone marrow itself, where someone can then have just a depletion of their blood cells. So advanced breast cancer, by definition, or late presentation, we're talking stage 2B or 3 to stage 4. Stage 2B to stage 3C. So when you look at the classification system, because your stage 4 becomes metastatic breast, it's sort of looked at differently. So there are things we look at when we're staging. We look at the tumor size or the lump size in the breast based on either clinical imaging findings. Then we look at the nodes, the underarm swelling, or whether, so the lymph glands, if they're involved, are they fixed, are they mobile? So you look at that separately, and then we look at whether the cancer has spread. So it's called a TNM system of staging. So based on the combination, then we will put our classification into early stage breast or locally advanced breast cancer. And then your third clinical stage will be a stage 4. So it's based on the size of the lesion in the breast, the nodal involvement, how many fixed or not. So it's N0, N1, N2, N3. So as you're advancing in these stages, you are going into a grouping that is more advanced. So I hope that that is understood, unless Miriam has a simpler way of explaining the staging to those listening.
No, thanks, Catherine. I think that was fairly comprehensive. I mean, what we just roughly say is, you said stage 1 is disease confined to the breast. Stage 2 and 3 are diseases, in the breast and in the armpit. The stage 3 is a slightly larger, more advanced disease than the stage 2, but both stages still have it confined to both the breast, plus or minus the glands under the arm. And then stage 4 is disease that has already gone beyond the breast, both the breast and the lymph nodes under the arm. Thanks.
Thank you. Miriam, I know you have to go. So I don't know do you have any final words, especially regarding quality of life post breast cancer diagnosis and support from loved ones.
Thank you. Thanks, Hannah. I would say the whole idea behind the treatment, so this is why we all, get up in the morning, come to work. I mean, it's all about successfully treating cancer and making sure that we're able to restore you fully, to, reintegrate you back to your life, back to your daily function and stuff. And so support does play a critical bit in the entire cancer journey. Support not just from your family, support from the healthcare providers, but we also, this is me making a pitch for mental health and wellness, just because counseling and psychological support is a critical bit of any cancer journey. And we tell patients upfront that, listen, I mean, this is kind of like, almost going through the stages of grief, because you're grieving a life as you know it. And sometimes you are going to go through, anger, thinking, you know what, I work out every day. Why is this happening to me? You may end up going through, bargaining. You're like, if I do this, Lord, then maybe this will work out. You maybe go through denial, where you're like, this is not really happening. And we slowly work your way towards acceptance. And it's not a straight curve. You're sort of going back and forth. And so what we try and encourage our patients to do, because sometimes there's still a lot of stigma around also mental health. And sometimes, telling a patient, listen, we have these supportive services, and automatically they're like, no, I don't have a problem. And we're saying, listen, it's actually a strength to recognize that you do need support, and everyone needs support, right? And what we see, especially amongst our women, is because they feel the need to be strong for their family, so then maybe not able to discuss what is going on, with them, what they're experiencing. And so we tell them it's a strength to recognize that you actually do need support. And part of the ways that we've also tried to do that is through providing peer-to-peer support through the cancer support groups. And I mean, it's fine for us to talk about your treatments, but sometimes it helps to have somebody who's been through the trenches, who's come through to the other side, who is actually able to provide some guidance and clarity. Of course, everyone's journey is different, but at least having somebody who's been through that and can give some advice and counsel and just support goes a long way. So I would say, let's not ignore our mental health. It is a critical part to successfully, going through the journey. And again, things like reconstruction that are sometimes dismissed by care providers as, cosmetic or whatever. We're saying, no, interestingly enough, breast surgery is the surgery that has the highest psychological fallout, just because of it's intimately tied to women and their identity. So even as we start to think about quality of life and wellness, let's change the narrative around reconstructive services, because reconstructive services anywhere else in the world are integral parts of, breast cancer management. And so if we're able to give these ladies not, it's not enough just to survive their cancers, but thrive and go on to wellness and complete lives, then that for me is a complete win. And then just to circle back to Catherine's comments around the multidisciplinary team, it's critical to have an entire team. And as we said, the different cancers, they all behave differently. And the idea of having a multidisciplinary team is getting this collective expertise with the patient always at the center, and us looking at how do we structure this treatment, because a treatment for Jane with the same cancer, different circumstances may be entirely different, say the treatment for Mary. And so having that team discussion makes sure that the patient is always kept at the center and the best possible treatment is provided to them. Thank you.
Thank you, and thank you so much for joining us. Catherine, also any final words, again, also pertaining to the quality of life as well.
Okay, yeah, thank you. I'm glad Miriam brought up the mental issue in terms of how sometimes we ignore it. The psychosocial impact of breast cancer should not be ignored. Again, just to encourage those listening that there's hope. You know, we need to not be afraid. It is obviously a life-altering, life-changing diagnosis, but it's something that should not be ignored. And that there's support out there. And within the context, I think, of our continent, mental health issues, I think that's where a lot of stigma is. And even within practice, you find that if you want to refer your client, let's say, to a psychiatrist or a clinical psychologist, dependent on what type of professionals you may have within your setting, they always feel, why should I be referred to a psychiatrist or to a clinical psychologist? So it's very, very important to look at this individual holistically, and as healthcare professionals within this field, be encouraging and doing research. I'd like to congratulate Dr. Miriam for her work in Kenya, and we continue as professionals also to advocate for improved breast cancer care. So that's what because it will lead to a good quality of life at the end of the day, and supportive treatments or rehabilitative treatments or caring for our clients when they've now reached the end of life, that is very, very important. So we don't shy away, and we shouldn't shy away from having sometimes very uncomfortable conversations. I think in medical school, none of us, I don't know about Dr. Miriam, but certainly I was not prepared to tackle issues of dying within the context of work. And it's been a journey, and I've learned a lot, even from our palliative care nurses, and just by having to look, because you have your patient who has very advanced disease, and they want you to give them hope, even when you feel there's no hope. But at the end of the day, we need to continue advocating for the patient. Thank you.
Thank you. Thank you so much, Catherine and Miriam, for joining us. This has been very insightful, and I've personally learned a lot today. And Dr. Asomang.
Yeah, no, thank you both so much. And I know this actually took a lot longer than we expected. It's such a rich topic, and I know we can go on and on, but I am absolutely grateful on behalf of Poor Hair for both of you. You've been on this for over 2 hours now. We have to be respectful of your time. We might have to call back on you, because it's, just because October ends soon doesn't mean breast cancer goes away as as the month wraps up. So we can definitely carry on this conversation some other time. So on behalf of Poor Hair, an absolute thank you to you, Dr. Mwaba. Absolutely thankful and grateful to you as well, Dr. Mutebi. Thank you so much, Hannah, for the moderating. Absolutely appreciate your time on a Sunday morning. We'll call the session to an end. And just for the viewers out there, next weekend, we're going to have an amazing mentorship talk with keynote speaker, Dr. Daryl Gray. Information will be posted on the various sites. So once again, thank you so much. And thank you to the attendees for taking the time out. Please share the knowledge. Let's support each other. Let's debunk those myths. Speak to a professional. If you have any questions, reach out to a professional. Once again, thank you all, and have a wonderful, wonderful day. Have a blessed week on behalf of Poor Hair.
Thank you. Bye, everyone.
Thanks for having us.
All right. Bye, everyone.